So thank you very much, and thanks for the opportunity to present. I first got interested in anti-doping when, in 2012, I competed at the World Under-20 Athletics Championships. And from that moment, a few of the big guys I was competing against, I knew they were on something. It then came out from several of them a couple of months later when they competed in the Olympics that they were doping. So personally, from that point, I thought that's something that I want to get involved in. Athletes often will push the limits, but sometimes it's our job as medical professionals to try and pull them back and keep them from hurting themselves. So I'd like to first acknowledge both my supervisors, Dr. Masako and Dr. Kenji Doma, for their support for this presentation. So slightly different to probably what you normally get at Grand Rounds, so hopefully you enjoy. So I'll just quickly go over the current problem, what the background literature is in the sport, and what we attempted to do to solve the problem, what our findings were, and where we go to from here. So nicotine is a potent psychostimulant, both caffeine and ephedrine. Both of those substances have quite extensive research to show that they're performance enhancing in anaerobic and aerobic performances. However, there's been very little studies actually done into nicotine, in particular nicotine-naive athletes, which most of the athlete population are. There's a study in 2011 that showed that 23% of the anti-doping samples collected by the world level athletes contained nicotine or one of its metabolites. So considering that less than 2% of high level athletes admit smoking even casually, I thought it was quite surprising that 23% of them had nicotine or the metabolites in the urine. And if you consider that the Olympics and the World Championships and high level events, all of our stadiums are all smoke-free venues, so there's very little chance that there was passive smoke exposure to these athletes. But when you actually went and broke down the sports individually, it showed that some sports had prevalences up to 56% of athletes having nicotine in their urine samples. So we thought that this warranted a closer look at nicotine's potential as a performance-enhancing drug in sport. Subsequently, after the paper I've just explained was published, nicotine was added to the wider watch list of the World Anti-Doping Organization. And the watch list is simply where they look for trends in doping to see if there's potential for it to be a drug that will be added to the ban list. And currently there's very limited studies into nicotine, as I said. So the proposed mechanisms obviously is a psychostimulant, but we have receptors located in the brain, the autonomic ganglia, as well as the adrenal and nervous system, and strongly activates the sympathetic system by stimulating adrenaline production, which has most of its cardiovascular effects. But there's also central effects such as increased motivational drive, but also decreased pain perception, which is quite useful in sports. Some of the problems is that there's currently only 3 studies investigating the effects of nicotine on exercise. And we know that tolerance is very important, especially with some of the central mechanisms. So the studies looking at smoking populations don't correlate with the outcomes that we expected to see in athlete populations who would be potentially using nicotine in very small doses, maybe once or twice a week, if once or twice a month. So very different effects to someone who's using heavy doses of nicotine daily. And also then some of the side effects that go with that sensitivity to nicotine. So as I said, nicotine is currently not banned or restricted. Both ephedrine, which is completely banned in competition, and caffeine, which is restricted. So you've got well-researched substances that are quite similar, both currently banned. So it's surprising that nicotine probably should be on that list at the moment. And there's no conclusive evaluation of nicotine's effects on anaerobic exercise in particular. So some of the literature review findings we had was that one study that found that a transdermal patch of 7 milligrams increased time to fatigue on bike riding by 17% in young fit males. However, some of the weaknesses in the study was that there was a 12-hour delay between the administration and the testing, and also the physiological parameters they tested didn't correlate with previous literature. 2 other studies were conducted more recently looking at anaerobic performance. One of them wasn't able to report any findings because of significant side effects such as nausea and vomiting, which actually meant that out of the 16 participants, all had to pull out with such symptoms midway through testing. And the last study found sort of no significant increase in performance anaerobic measures. However, neither of these studies utilised side effect surveys or biomarkers to see if they actually absorb the drug or not. and there wasn't any physiological parameters reported, so purely only performance parameters, so quite ambiguous. So currently we're looking at transdermal administration being quite unpractical for athletes. As I said, there was a 12-hour delay. I don't think athletes are going to be putting on that patch the night before performance. So it's quite limited. It also limits the dosing that these athletes could use. And there's no studies looking at any of the repeated performance or exercise, which we know in most sports like football, AFL, any of your sort of main team sports where you have repeated bouts of anaerobic performance, so short sprints. And the other studies show that prolonged oral absorption routes tend to appear to show increased side effects, particularly in nicotine-naive athletes, which is probably impacting the performance of those studies. So our current study aimed to determine the effects of a rapidly absorbed form of nicotine, and we used an oral strip on repeated high-intensity anaerobic performance exercise, perception of exertion, and a range of physiological variables. Our hypothesis was that the consumption of rapidly absorbed nicotine minimised the gastrointestinal side effects while concomitantly enhancing repeated anaerobic performance and the physiological parameters we tested. We had 16 male participants with average age of 24. We had quite strict inclusion-exclusion criteria. All of our participants were very fit, and most of them were high-level athletes or elite-level athletes. So they all did at least 45 minutes of exercise 3 times a week, each session containing elements of strength and power. They were all between the ages of 18 and 40. We excluded anyone who'd smoked more than 10 cigarettes in the past 5 years, or they had sustained passive smoke exposure in the last couple of months, or if they used any other nicotine-containing products. We used a randomised double-blind placebo-controlled crossover design, so everyone acted as their own control. Everyone had first a familiarisation session, and then we conducted a repeatability session following that, which we compared the data from that to placebo to see how reliable our repeated anaerobic test was. We actually came up with a reliability factor of 99.7% between the placebo and the repeatability study, so it was a very reliable test that we used in this cohort. Following that, they had a randomised order between both of the intervention sessions. So the testing protocol, we had a baseline observation, so heart rate, blood pressure, as well as taking blood tests to see that they were clear of any nicotine or metabolites, so they were both before and after did those tests. We then looked at a BATAC reaction time test, which is a 30-second multi-stage reaction time test. Before and after that, we then gave them an intervention, sat them down for 5 minutes to rest, and then did side effect surveys to see if there was any baseline differences between nicotine and placebo. We then repeated this at the end of the testing to see what the effects of both placebo and nicotine were on side effects following exercises. So we then did a 5-minute warm-up on a cycloergometer, and they then performed repeated 30-second Wingate tests, which are 30-second all-out bike sprints against 7.5% bodyweight resistance, with myself giving verbal encouragement the whole time to make sure that they're giving it everything they've got. We then gave them some side effect scores and got them to rate their perception of exertion out of 20, which is a broad scale. Following this, we gave them final blood venous samples and looked at the blood lactates. For the statistical analysis, we used parametric statistics with repeat measures 2-way and over being used, and we presented all of our data as means plus or minus standard deviation. And we then undertook a post-hoc 2K test to look for any other trends with the alpha value set to 0.05. So first of all, the cotinine results showed that all athletes had a significant nicotine absorption, and they all had baseline scores of 0, both pre-placebo and pre-nicotine, which means that we had enough period of time between sessions so that there was a flush out, and that also none of our participants had been pre-exposed to nicotine. So we were quite happy with the result we got for that. The main measure that we used for the anaerobic performance was peak power, which is the absolute top score that they were able to produce. And on average, we saw that for the first bout, we had an increase of about 11.4% compared to placebo. And then also in the second bout, we also had an increase as well, but it was to a lesser degree. There was also a main effect for time as well, but significant reactions for both the first and second bouts compared to placebo in this case. Similarly, we observed a similar effect for average power, which is the power that produced over a 30-second period, both in bout 1 and bout 2 being significantly higher than placebo, but to a lesser extent than what peak power was. Heart rate was significantly elevated post nicotine consumption. However, post placebo, the heart rate stayed fairly steady, and at baseline they were quite level. So we were quite happy there that we weren't getting any other effects, and that there was that strong sympathetic effect that we hypothesised was involved there. We also saw a similar effect in the systolic blood pressure, but also in the diastolic blood pressure. So we're quite happy that the similar trends were occurring there. Very interestingly, there was no significant difference in the side effect survey scores post consumption of either nicotine or placebo. So they both scored baseline pretty much the same, about 1.4 to 1.6. However, quite interestingly, while there was no main effect for nicotine, there was a significant effect for time. But as you'd expect, if you've just done 2 30-second all-out bike sprints, you're going to be pretty tired. So some of those measures are fatigue, pain perception, nausea. But what was significant was that nicotine actually reduced perception of fatigue, nausea, pain, which was quite significant considering that in other studies they showed that nausea was normally elevated. So using a rapidly absorbed form of nicotine reduced the effects of exercise on these participants. We had some non-significant effects in reaction time, also minimum power and power drop, which actually we're hoping to see because it means that there wasn't a drop-off effect in fatigue. Rate of perceived exertion was non-significant, but with the way that we did the methods, they were both scoring 19 out of 20 on both placebo and for nicotine, so it probably wasn't as sensitive a test as we could have used for that. And there's also no significant difference for blood lactates, which in itself is interesting as they gave more work output during nicotine, but their blood lactates were the same, so it was probably an effect of increased blood flow. So in summary, we had a strong sympathetic response with increases in heart rate and blood pressure, very significant, as well as increases in peak power, especially in bout 1 by 11.4%. And to a lesser extent, we saw similar trends in average power, and we also saw a decrease in side effects post repeated Wingate tests compared to placebo. And as such, we concluded that our hypothesis held that there was a decrease in the side effects and an increase in performance parameters. So our findings are comparable to a literature review that we did, where we found that 21 out of 24 studies that assessed nicotine on nicotine-naive participants showed significant increases in heart rate, with a similar trend for blood pressure as well. So at least for our physiological parameters, we were quite happy that they matched the current literature. Our study was similar to Mundell and Jones, which showed that 17% increase in endurance findings. They did contrast the findings of SIDL, but as I said, there was quite limited parameters assessed in that, and given that they didn't assess side effects, the oral consumption could have contributed to that by a masking effect through side effects. The strength of the current study was that we used quite strict control of confounding factors, and that we utilised biomarkers both pre and post testing, which is something that most of the other papers didn't do. We also added some new elements to the literature by included repeated bouts of performance, which is extremely important in most sports, and also the use of side effect surveys, which is not done by any of the other literature papers in this area of nicotine, and assessed physiological responses and able to match up performance findings to those studies. So the weaknesses, though, is that it was quite hard to attract people when we had such strict inclusion criteria. And it turns out that most of our high-level athletes don't like getting needles in particular now, so it made it a bit more difficult. As I said, repeated anaerobic bouts are hard enough just when you're doing one, but to do 2 of them was quite challenging for some of our participants. The underlying mechanism was probably due to an increase in the sympathetic stimulation, as I talked about, but we could also see that there's an increase in motivational drive and a decrease in pain perception, which was indicated by some of our side effect score findings. And a recommendation is that the World Anti-Doping Organisation needs to look into possibly restricting nicotine, but there's obviously some further studies that need to be done to, again, look at some of the different forms and also to add to the wealth of literature. So it's important that we look at some more of the rapidly absorbed forms of nicotine. For example, there's also the sprays, which have no literature in them at all, and lozenges, there's no literature at all. So of these new rapidly absorbable forms that have only recently been introduced, there is a vast lack of literature of any source, let alone in the sports science area. We also think that there should be some more studies looking at the usage of non-tobacco based products in athlete populations. We know that some use snus, but there's no sort of any recorded data on athletes who are trying to quit smoking or who use other forms of nicotine as a performance enhancing drug. The clinical implications is that for us as clinicians, nicotine gums actually taste really foul, and most people I talk to who are ex-smokers don't like them. Some will, some won't. But they do have the potential to cause significant side effects even in smoking populations. So this may put off some of our people who are trying to quit. Potentially some of the more rapidly absorbed forms of nicotine may help avoid some of these side effects. So they might actually help adherence to smoking cessation plans and the use of nicotine replacement therapy, as well as having a much faster absorption rate of approximately 2 minutes compared to 30 minutes is the case with nicotine gums. And interestingly, there's also currently appeal to the TGA to look at having nicotine use be allowed recreationally as opposed to just therapeutically. And this is a big push with the globalisation of vaping. But that does come with some problems. So if that's allowed to happen, we could see that nicotine trying to be added to sports supplements, which already is a bit of a contentious issue, and it could provide a wealth of very dangerous and addictive supplements that already pose cardiac and psychological risk factors to the general population. So we wouldn't want to see nicotine added to this in the future. So in conclusion, we looked at 5 milligrams nicotine compared to placebo using a rapidly absorbed form and showed that we had increases in peak and average power in male athletes compared to placebo. That was quite significant. We need to continue to further monitor nicotine and to look at it as a potential performance enhancing drug, both for the potential for athletes but also for a more broader general population view and preventing possible side effects from contamination of supplements. Thank you. Any questions?
Sorry, these strips, how are they administered, and could the participants taste any difference and so on?
Yeah, so they're oral dispersible films. We matched the placebo with a Listerine oral dispersible strip. They were both flavour matched. We then also looked at we asked each of the participants afterwards to guess which order they had it in, and the correct order of guessing was about 60%, so we were all quite satisfied that it was randomised.
And so how are they applied inside on the
So they're both placed either on the top of the buccal membranes, or you can place them under the tongue. And it's absorbed to between about 30 seconds and 2.5 minutes. So we're actually using 2.5 strips, so the absorption time is probably a little bit slower than had it been just a single strip. So we had one participant that actually swallowed saliva containing the nicotine in that period. We told most of them to wash their mouth out afterwards, and he scored about 15 on the side effects survey, which compared to the one that we had, he actually had a negative effect on performance. So it actually showed that if they were ingesting the nicotine into the GIT tract, that it correlated with what one other study had found. So potentially that masking effect of nicotine on performance.
So the amount of nicotine that's administered in a strip, how would that relate to what would be in one cigarette?
Yeah, so a standard cigarette is somewhere between 0.8 milligrams and 1.4 milligrams of nicotine, depending on the brand. We use 5 milligrams. The previous studies had used 2, we're using 4, and one was using 7, and another used 8. That relates previously to if you'd spend 3 hours in a Melbourne pub having a meal before the ban of smoking, and so we realised that most people previously were being exposed passively to those sort of doses, so quite safe and for the general population.
But it was more than one cigarette?
More than one cigarette, yes, equivalent to about 3 cigarettes, but without the respiratory irritants of a cigarette.